Thank you very much. It's a pleasure to be here. We spoke, or I listened to talks in the morning on cigarette smoking and exercise, and now we're jumping to stem cells. So I thought this would be a good slide to start with. Don't panic. And these are the three most common diseases at our institutions that we do stem cell transplants for in terms of autoimmune disorders. And there are certain just simple statements to remember for each of them. And for MS, the first is no inflammation, no response. What that means is that this therapy will not work in progressive MS, primary or secondary. It will work in relapsing remitting disease. And the reason for that is this is an immune-based therapy. So there's a lot of confusion out there when I look on the internet and even listen to other speakers when they talk about this type of therapy, and that is this therapy is not designed to regenerate neurons. It's not designed for remyelination. The hematopoietic stem cell doesn't do any of that. What this is really the concept of antigen presentation without co-stimulation induces tolerance. That's a well-known laboratory observation. What we did is apply this in the clinical arena by using an immune-specific conditioning regimen to knock down your immune system and stop inflammation. If you stop inflammation, that's the correlate of stopping co-stimulation. We then allow the hematopoietic or immune stem cell to rapidly regenerate a new immune system in a non-inflammatory environment where it defaults to tolerance. That's the rationale. So I think there's a lot of confusion about this. So basically, if you oppose this therapy, you oppose all types of immune-based or immune-modulating therapy for MS that's been going on ever since treatment has been started for this disease. It's the same rationale. It's a little different because we treat more intense at one time and no more treatment after that, none. Unlike drug therapy or pharmacologic or drug-modifying therapies that you keep treating the patients on until they fail and then you switch to a different one. This is a one-time treatment. Just quickly, we do a lot of CIDP, and the real question, is it CIDP? About 2/3 of the patients referred to us for transplant for CIDP having failed IVIG and plasmapheresis really don't have CIDP by the European Federation Neurologic Society, Peripheral Nerve Society's criteria for definitive CIDP. And finally, for systemic sclerosis, the key is it's a matter of the heart. The heart's always involved in this disease. It's overlooked, and it determines whether they're going to survive transplant or not. So we have to carefully work up the heart, cardiac MRI and cardiac cath with fluid challenge. And in fact, we have to modify the regimen we use based on the cardiac function. That's very important, and I think that'll be the future in this, this treatment. But importantly, and the reason I have it here, is there's been 3 randomized trials now for stem cell transplant for this rheumatologic disease, systemic sclerosis. The first one was done by us at Northwestern, reported in Lancet, and we stopped it early because transplant was so much more effective. Then we continued and reported again in Lancet 2013, all the final results. After that, the Europeans reported their study in 2014, and after that, another American group, the Fed-Hutch Consortium, reported their results in New England Journal in 2018, this year. All 3 of those studies, all randomized, are markedly positive for stem cell transplant. And so this fall in Chicago, they had the American Rheumatology Society meeting, American College of Rheumatology, and I noticed a very perceptible change in the attitude of the rheumatologists. It's now an accepted therapy, whereas at the beginning, they were very, very critical of it. I'd say as critical as neurologists are of stem cell transplant. So this has changed things. There's not going to be another randomized trials. 3 are done. It's now fine-tuning transplant to even make it safer. And I think that's the main concern that strikes everybody, safety in what we're doing. That's the #1 concern, and I understand that. And in fact, survival was markedly better on the transplant arm than the drug arm in these trials. But of course, that's a different disease than MS, and the risk-benefit ratio is different. So safety is the key, and what I want to emphasize is that's why I always say we do non-myeloablative transplants. We don't even have to give the stem cells. They will recover fine if we don't, but about 4 days longer. And the shorter you make that neutropenic period, and the shorter they're in the hospital, the safer the procedure. And that's why we give them. They're really an autologous supportive blood transfusion. That's what's really going on with that. So, and there are different types of regimens. There are still people using these myeloablative regimens for transplant and MS. They're more toxic. They're higher risk. And of course, we want to minimize risk when we do this treatment. So anyway, before we go to the next slide, I just thought I'd show you this. This is a Tesla roadster that is in space, fired on a SpaceX rocket on its ways to the Martian asteroid belt. And this is from the camera on it, actually showing that picture. So, all right, so this has been a long road for me. I first had this concept as a fellow at the National Institutes of Health and at Johns Hopkins. And I thought, you know, in 5 years I'd have all the answers, and it definitely doesn't work that way. And by the way, another important distinction between what we do and what's being done out there in the literature is we have zero, nada, no pharmaceutical support. There's none, so I don't list it as a conflict of interest. There's no pharmaceutical support in what we do here. There never has been. But my first paper on the concept was reported in Bone Marrow Transplant in 1995. And we did preclinical animal models, and these are two of them. One's in EAE and one's in TMEV. And then we started reporting clinical results. But I wanted just to this audience to notice we were pretty much limited to hematology journals. There just wasn't interest from the neurology community. Finally, we had a clinical result published in Lancet Neurology 2009. And then our most recent paper in JAMA in 2015. I'm going to show you that before we go to the randomized results. So we've completed a randomized trial, and we haven't published it yet. We're going through the peer review process. So I notice this is being filmed, and I asked you not to release the film until it's published because the journal has asked that of us. So, and I've also had to hold back a little bit on some of the results per journal request. But in any event, this was already published, and this is, you know, good rationale why we need to do a randomized trial. 151 patients in JAMA 2015. We had no mortality, importantly. Remember, this is non-myeloablative, but it's non-randomized, and it's open label. And only one death, and that was a cardiovascular death from a patient that had poorly controlled hypertension and didn't take antihypertensive medications. This is the regimen we use, and this is non-myeloablative. It's cyclophosphamide rapid ATG with peripheral blood stem cells on day 0. So these are immune suppressive medications. They don't touch the stem cell compartment in your bone marrow. You will recover even if we didn't collect and give you your stem cells back after this regimen on day 0. It'll just take longer for you to recover. So again, the key here is it's non-myeloablative, and you kind of have to pay attention in the literature. Most other centers use myeloablative. Well, that's changing. They're switching to this approach. And the details from that paper are important again, is most of our patients were relapsing or remitting. The vast majority, you see marked improvement. Those who were early secondary progressive, we'd already reported in another paper, and we were forced to start initially by our advisory panel with secondary progressive. Our animal models predicted it wouldn't work there. It didn't work. So we won't do late secondary progressive, but we did a few, you know, in transition, early secondary progressive. It didn't help them. You could argue maybe it slowed progression, but to me, that's a question couldn't be answered without a massive number of patients, and it was not impressive, and it's not why we do this. So don't do progressive disease, do relapsing remitting disease. And this is a problem for this field because there's a tendency for neurologists to want to give all their medications, including Ocrevus and alemtuzumab, and then at that point, refer them for transplant. But at that point, they're most likely in progressive disease. And the hematologists who do it don't understand MS. They're not going to know relapse and remitting from progressive. So we've overcome that because we have a separate division. I left hematology a long time ago. I used to transplant leukemias. I gave all that up, I don't know, 18 years ago, and our whole division is only stem cells for autoimmune disease. And so we've forced ourselves, to become experts in MS. If in this paper, and this actually isn't in the paper, it's in the supplement, and I did put it in the supplement intentionally, not in the paper, is that independent of age, we had marked improvement in EDSS. You see the youngest age, 18 to 25, had the most. 26, 36, even older, our oldest was 58, we had improvement. Not as much, but they improved. The reason I put this in the supplement instead of in the text itself is I was always worried people would see this and say, we're going to transplant old people. Well, most old people are no longer relapsing remitting. So a few are. So you have to be very careful in how you interpret that data. And here's very important, and this is different than your transplanters who transplant in oncology. If you get a fever going through a transplant in oncology, they'll never give steroids. They're scared stiff when they're neutropenic. They're going to get septic. So they won't do it. But if we look here, if we had persistent fever, especially high fever over 39 or over 38.5, at least 3 times checked 4 hours apart in a 24-hour period, we saw that initial improvement, but by 1 year, those that had that fever didn't do as well as those who did not. And we know that, most people don't know that. You want to avoid that fever. Not only that, that's late, but of course early they get that fever and they just fall apart. They may not even be able to move. That's a pseudo-flare from fever, especially if it's a high fever, 104 degrees, or 38.5 or 39, and you'll do an MRI and everything. There's no new enhancing lesions, nothing. The key is you give steroids and the fever breaks, and in half hour, they're doing fine, they're up walking again. So fever is due to ATG. Not always, be careful, be thorough, look for infection, but it almost always is ATG. And we already use preemptive antibiotics, so what we do is treat with Solumedrol. It breaks the fever, the patient does much better in half an hour. As I say, they're doing very well. They're already on a 3rd generation cephalosporin. We add vancomycin, get a chest x-ray, do blood cultures, check urine, including for Legionella. They always end up negative, but you have to be careful. And it's just a remarkable turnaround to see when they get those steroids. And this is unique to MS. We don't see this high fever from the ATG and other diseases. So what I wanted to show you is the results of our study in relation to others. And so here's 3 studies. This is our study in JAMA 2015. Had 151 patients. This is the Swedish study out of Uppsala by Berman. Dr. Berman had 41 patients. And this is the HALT trial out of Seattle. It had 25 patients. And if you look at NADA, no evidence of disease activity, so it's NADA 3. No clinical attacks, no progression, and no new lesions on MRI. These are the results. And that NADA is fairly high. And how does it compare to DMARDs or drug-modifying therapy? Well, here's the comparison. So it's about double, which is really impressive. But there's a caveat here. These are generally randomized blinded trials. All 3 of these are non-blinded, open-label, non-randomized trials. And so you could explain the results or be skeptical of the results because of that, but it tells us that we need to do a randomized trial, and we've done it, and it's completed. And that's what I'm going to talk about for the rest of my time allotted up here. It's called the MIST trial, Multiple Sclerosis International Stem Cell Transplant Trial, involving 4 centers: America, University of Sheffield, the UK, University of Uppsala in Sweden, University of São Paulo. Everybody's at least 1 year. The mean follow-up's 2.8 years, 1 to 5 years range, and we will continue to follow everybody for 5 years. Importantly, the evaluating neurologist is blinded, doesn't know what treatment they got. I think that's very important for credibility. Unfortunately, you cannot blind the patient. There's no way they're not going to know what treatment they received. And here's the study design. We had 916 inquiries. Most of them failed a phone screening. Some came on, were evaluated, history and physical, and failed. The most common reason for failure was either not 2 relapses in the last year, which was criteria to go on the study, or they had progressive MS. There were other reasons, but those are most common. We enrolled 110, 55 in each arm. We had 51 evaluable on the drug-modifying therapy arm. 4 we lost because they left the study to get a transplant somewhere else. So they're just lost from the study. So we're down to 51. Over here at 55, 52 evaluable. 3 we lost. 2 initially enrolled turned out caught very early to be secondary progressive MS, and we, contacted every PI as well as the FDA, and then censored them because they clearly were secondary progressive. Those were in the early days, again, with neurologists not understanding that's the wrong group of people to treat. And 1, after enrollment before treatment, was having recurrent infections, so we just decided not to treat that patient. And here are the characteristics of the 2 groups, and they're very similar. So this is the drug-modifying therapy in the transplant group. The randomization, you see sex, ethnicity, or race, age, duration of disease, prior immune modulating meds. What I want to say here is the only thing that looks like it may touch significance between the 2 groups is duration of disease. The drug arm had longer duration of disease, but we had our statisticians look at that in mixed effect modeling, and the duration of disease had no impact at all on the primary outcome, which was progression. Although it's not significant, it's close to it. And then I want you to notice, unlike drug company trials, a lot of our patients already had a lot of different treatments before they came to this study, because this wasn't upfront treatment, okay? It was never designed to be upfront treatment. And then the number of different immune modulating drugs that they had, the same in both groups. A baseline EDSS, the same in both. Number of enhancing lesions, the same. And it's cut off from here, but it'll be in the paper. The T2 lesion volume was the same in both groups. So both groups ended up by randomization to be very similar. And this is the study design. So the primary endpoint was increase in EDSS by at least 1 point sustained for at least 6 months after at least 1 year of treatment. So you couldn't cross over until you've had at least 1 year of treatment. 110 patients, 55 in each group. They had to, on enrollment, have an EDSS of 2 to 6 with 2 relapses in the prior 12 months on a DMARD therapy. It's important, they had to be on therapy. And they were randomized either to continue DMARDs, in which they had to switch to a higher or other class of DMARD, or to transplant. And here's the DMARDs that they received. Now, we didn't dictate which DMARD. We left that up to the evaluating neurologist, not evaluating, treating, excuse me, the treating neurologist. The evaluating neurologist had no idea what the treatment was. So these were the treatments they ended up getting. In addition, they were also allowed to give treatments that are very well accepted for this disease. They're not FDA licensed, but they're accepted in bad disease. IV cyclophosphamide, rituximab. This was before Ocrevus, and in America, people were using rituximab. IVIG, plasmapheresis, and corticosteroids, of course, very common. Here's our transplant regimen, and again, you continue therapy, you can switch. We allowed them to switch drug-modifying therapy if they wanted to. Over here, this is a one-time treatment period. You're done, no more therapy. 52 and 51. But again, after 1 year, if they progressed, having met this by the blinded evaluating neurologist, they could cross over. And here's the toxicity on transplant. Of course, that's always the key and the concern for what we do. There were no deaths, no grade 4 toxicity. Every patient has the NCI-CTC common toxicity criteria grading of all organ systems. And there were no grade 4. Grade 3, the most common was culture-negative neutropenic fever. The second most common were electrolyte disturbances, potassium or phosphorus, basically. 1 bacteremia during neutropenia, and we felt that was a contaminant because it was a skin contaminant, staph epi, in only 1 of 3 cultures. No early or late opportunistic infections, no CMV, PCP, PML, Epstein-Barr virus. It's very important to note, though, details are important. And we put in the trial DMARD clearance. So if you had come to us on Gilenya, you had to be off at 3 months before we could do a transplant. Of course, you were reevaluated for all your scoring. But we put in that drug clearance interval because I'm always afraid if someone has transplant, and I've never seen that happen. I've transplanted a lot of people in my life, but that they would get PML. And of course, the community in this audience would say it's a transplant. And I think that would be partially right, but it would also be the drugs they got before, the Tysabri or the Gilenya or whatever. And that's why we put in that clearance. And Tysabri was 6 months. But in any event, we never saw any PML. And here are the results. And again, this was the EDSS by the blinded neurologist. The blinded neurologist also did the NRS. But you can see in the ones that had continued drug-modifying therapy and what's really highly active MS, they continued to decline. This is the mean of everyone. And the ones got transplant, there was an improvement. This was highly statistically significant, especially if you look at the difference in the means between the two groups. In any event, here's the NRS. Again, the transplanted improved. The ones who continued on drug-modifying therapy, it did not. It even worsened. And we have over 10 secondary endpoints we looked at. I just don't have time in this trial to show you, like the PASAT and time 25-foot walk, the quality of life. Very interesting. Quality of life markedly improved. SF-36 by like 20 points in the transplant arm, and it got worse on the continuing drug therapy arm. People are depressed because of MS and continued drug therapy. If you make them better and they get off drugs, their quality of life gets much, much better. Something not reported in all these great trials, MS Care 1, et cetera. You read it, there's no mention of quality of life. It'll be in our paper. But in any event, that all correlated with T2 lesion volume, percent change. So if you look at the percent change on each person, everybody starts at 100, and you can see it got worse on continued drug therapy, and it improved on transplant, even though you only got treatment here and all treatment stopped. Improvement was quite amazing. We had all these double-checked by Flavia Nelson, who's a kind of MRI guru at the University of Texas, now at the University of Minnesota. Importantly, relapse-free survival. Here's here's the transplants up here, and here's DMARDs. So the DMARDs were relapsing. And if we looked at time to progression, which was the primary endpoint, here's the transplant group, and here are those who continued on drug-modifying therapy. The progression, these are highly statistically different. And they're actually more than 0.001, but we've been requested to cut it at there in our publication, so that's what it'll say. And again, progression, was a blinded assessment. If we look at NADA, no relapses, no progression, no new or enlarging lesions. Again, it'll be cut at 0.001, but in any event, here's what it was after transplant. Here's what it was on continued drug therapy in these highly active relapsing remitting MS patients. And again, this drug therapy is different than all the drug trials out there. All the drug trials compare their drug in the early days to placebo and now to interferon or Copaxone. They don't compare it to anything else. Why should they? They want the trial to succeed. This was compared, you could use Gilenya, Tecfidera, Tysabri, any FDA-approved drug, except Ocrevus and Lemtrada, which I'll come to in a minute. So it's actually a much more intense comparator than anything done with even the newer drugs, alemtuzumab or Ocrevus. And so again, if we look at the design of the trial, 51 DMARDs, 52 HSCT, but at 1 year, you're allowed to cross over, or any time after that, if you progressions increase in EDS by 1 point sustained for at least 6 months. 31 at the time of the production of this slide, now more, and also 31 at the time we originally wrote the paper, have crossed over. So 83 total transplants, and I think for you, you want to know not only what happened in the first year, but what happened to the total number of these transplants, the ones that crossed over. In the paper, we report these separately that went to transplant and these separately in the total group. And I'll only show you here the total group. And if you look at the total group, all 83, marked increase in EDSS that just remained stable. Remember, we stop all therapy after that. Not increase, decrease, improvement in EDSS, excuse me. And if we look at change in T2 lesion volume, again, the same type of thing. This is in all 83 patients. And what was amazing to me, this is percent change from baseline for all these patients. Even out here from 3 to 4 years, it's improving, maybe a little bit even from 4 to 5 years. Again, this therapy, the hematopoietic stem cell does not become a neuron, but I think what happens if you stop inflammation, the brain in the relapse remitting phase can still repair itself, is what I think is going on. And it's remarkable to see that kind of change. And this type of change is not seen at all in the drug-modifying trials. In fact, Flavia Nelson didn't believe it. She came up, reviewed our MRIs. We sent her MRIs blinded for her to review at her center, and now she believes it. So this is the trial. It's completed, and these are the centers and the people involved. The neurologist I work with closely, Dr. Balabamoff, and of course, Dr. Nelson, the MRI guru, the University of Minnesota. Here's, in the UK here, the University of Sheffield, Basil Chirac, who's in the audience with me today, John Snowden, who's the transplanter, again, Sweden and Brazil. Those were the 4 centers. And so I want to talk about these are really, I think, exciting, stunning results, and I've often found the more exciting I am about the results, the newer they are, the more difficulty I have getting it through the peer review process. But in any event, there are limitations. Here they are. The crossover prevented long-term follow-up on DMARDs. To your pure statistician, they're not going to like the crossover, but the truth is we, even with a crossover, lost 4 patients on drug-modifying therapy who went somewhere else for a transplant. If we didn't have crossover, I don't think we could have completed the trial. And the reason is times have changed. Patients talk on the internet all the time, and they find other patients. Matter of fact, we'll talk to a patient in one room, go to the next room, they are telling us what we said to that patient because they're already on the internet with each other. So the patients on the transplant arm all knew they were doing good, and the patients on the drug arm knew they weren't doing good. If we didn't have that crossover, this trial would have never been completed. We had a small number of patients in this trial compared to drug pharmaceutical trials, but that was calculated from the beginning on the assumed efficacy of transplant compared to drugs. And that calculation, originally done by our statistician, held up. It was a very good guess. On our trial, on the drug arm, again, you can get any FDA-approved drug or standard non-FDA-approved drugs at the time, like cyclophosphamide, plasmapheresis, IVIG, or rituximab, but there was no Ocrevus, ocrelizumab, and that's because it was not licensed by the FDA till 2017, and our trial completed in 2016, and no Lemtrada or alatuzumab, and we did that intentionally. It was licensed by the FDA in 2014, but we didn't include it because there's a really high risk of secondary autoimmune B-cell-driven disorders in people who get alatuzumab, and I'm afraid that would occur in the crossover group. The other is we found alatuzumab tends to have a very profound effect on suppressing CD4 cells in some patients for a very long period of time. And I'm figured we don't know how long we have to wait after alatuzumab before we can safely do a transplant, but those CD4s will be very low, and I'm worried they're going to get something like PML. And everyone say it's transplant, but it's the combination of the two. So we said, you know, nobody got alatuzumab. The EDRS and NRS were done by a blinded neurologist, but relapses were by an unblinded investigator. And importantly, the results from this trial are for highly active relapsing remitting MS, failing at least one line, and often more than one, of disease-modifying therapy with moderate disability in the range of 2 to 6. And that's very important. This isn't going to work if you're doing high disability, that's secondary progressive or primary progressive. And I worry about these new trials being designed where they're doing it with an ED upfront or EDSS of 0, because I think you're going to have to do a lot more patients to see that difference in progression, because you're dealing with probably a lot of people who won't be progressing very rapidly. If you deal with highly active disease, already failing DMARD therapy, you're dealing with people who are more likely to progress rapidly, and that's probably why our trial required so few patients to show such an effect. So you have to put these caveats in there as limitations of our study. So where do we go now? What comes after the MIST trial? We got to get it published, and we're working on that. We want to do a cost analysis of transplants versus drug-modifying therapy, because I actually have, from developing this field, have a very strong feeling that it's going to be highly cost-effective compared to DMARDs, at least in America, because they're so darn expensive. And so it's a win-win. It's a win for insurance, or it's a win for government health, and it's a win for the patient, because they're actually seeing things they've never seen before. Their EDS gets much better. They get off all therapy. Their quality of life markedly improves. And again, I didn't show you that. And we've designed a new trial, maximizing outcome of stem cell transplants. So while the rest of the world is going to try to repeat our results, hopefully get something similar, again, you have to be careful how you design the trial, because patient selection is key to getting these kind of results. It is a very powerful therapy. Don't do it too soon. It's not going to work too late. You've got to get the right group of people. Any powerful therapy has to be respected and has to be done by people with experience to get really good results. You can't take it in a cavalier fashion or attitude. Anything that's very powerful has to be respected. But we've designed a new trial comparing our standard way to a slightly different way of doing it. The results are so good, I don't want to change it too much, but we think we can perfect it even more. So we want to move in improving both safety and outcome of transplant rather than any further comparisons to drug-modifying therapy. So here's where we are as today, and Professor Chirac sent me this, which I thought was kind of cute. And this is me. And I'm down here next to the Grim Reaper right now. So tonight I won't be joining dinner because I've got to respond to the Grim Reaper. But we're getting very close. And then I thought this was important. This was not our group, but another group in America reported in neurology. The costs of these drugs, which really surprised me, they're all about the same. Yes. That was a good question. I'm not going to answer it. You can wonder why and answer yourself. But it surprised me that they were all about the same and they were so expensive. Now that's the cost of the drug alone, not infusion if it's an IV infusion, not the physician fee, not MRI, not any drug monitoring or CBC or Angelina, cardiac rhythm strips, whatever, none of that. That's just the drug. And they estimated that the cost to prevent a single relapse is $80,000. By the way, Lemtrada isn't up here. 1 year of Lemtrada, the 5 days, then the 3 days. In America, just the Lemtrada drug alone, no physician fees, no infusion costs, is $156,000 US. A transplant at our institution doing non-myeloablative is $125,000. And that's why I'm excited about doing a cost analysis. And our university's approved the position. I'm looking for the right person to do it because I certainly don't have the expertise or time to dig into what is really an important area for us. And we had the position approved as assistant financial analyst. We found the right person. She said she'd only take it if she was associate. We had to go back, work at the university. It took months to get it changed to associate, and by then she already had another job. So we're looking for a good person. If there's anyone you know interested, please send them our way.
Richard, are you getting close? You are.
Excuse me?
You're getting close to the end?
I'm done.
Oh, good.
Here is my last slide.
Sorry.
I just asked you to throw that in, but that question planted. So here's HST for MS. This is us. We're in downtown Chicago where the medical school is. And so is the paradigm for MS changing? And we've got our new trial going on. Thank you.